Welcome to Genomics Now, a podcast series where you can learn how genomics is developing in England's NHS. This podcast series is recorded in 2024 and is part of the North Thames Genomic Medicine Services Educational Toolkit. In each bite-sized episode, we explore what is changing in genomics. We answer the questions on genomics we've been asked by the different healthcare professionals. We talk about the ways genomics may impact different healthcare roles, and how genomics can be used to successfully improve patient care. Hello, I am Dr. Shazia Mahamdallie, and I'm part of the North Thames Genomic Medicine Services Workforce Education and Training team. This is the first episode of our 5-part podcast series on pharmacogenetics, an area that is rapidly developing in the NHS in England, a core component in next-generation healthcare, and is already being used to guide a personalised approach to medicine's optimisation. In today's episode, I'm joined by Dharmisha Chauhan.
Hi, I'm Dharmisha. I'm the Lead Pharmacist in North Thames Genomic Medicine Service Alliance.
Thank you so much for joining me today, Dharmisha. Can we start at the beginning, Dharmisha? Can you tell us about what pharmacogenomics is and what the difference between pharmacogenomics and pharmacogenetics is?
Yeah, sure. So pharmacogenomics and pharmacogenetics is the combined study of pharmacology and genomics. So it's where we want to understand how an individual's genome affects the way we select treatment, the doses that we give, and how we can use a patient's genomic information to stratify them into the correct treatment groups or treatment regimens to make really a tailored approach to their treatments. Within the field, pharmacogenomics and pharmacogenetics, it's really used interchangeably, but I normally like to split them out. With pharmacogenomics, we are really thinking about the whole genome, the coding and the non-coding elements, which will involve many variants across a lot of different genes, both in the RNA and the DNA. A good example of this is using polygenic risk scores to stratify patients into different treatment pathways due to their personal risk scores. So, for example, the risk of cardiovascular disease and those that will require prophylactic medication. Within pharmacogenetics, here we are thinking of a much smaller select number of variants across a few selected genes. An example of this is testing 4 variants within the DPYD gene to find out if the patient in front of me is a poor metabolizer for the drug 5-FU or fluoropyrimidine and capecitabine.
So just really briefly highlight that difference, Dharmisha. Would it be right me saying that pharmacogenomics considers the whole genome, while pharmacogenetics focuses on a small number of specific variants in selected genes?
That's correct, yes.
Thank you. So can you tell us a little bit about the ways in which pharmacogenetics is currently being used in the NHS?
Yes, so we have DPYD, which I just explained briefly, and this is a test that is used within cancer units for a drug called 5-fluoropyrimidines. So it could be 5-fluorouracil or capecitabine. And these drugs are used in colorectal cancers and breast cancer predominantly. And we try to, as best we can, to preempt every patient before they get treatment with these drugs so that we can identify who is at greater risk of side effects such as mucositis, diarrhea, and neutropenia, which can lead to inpatient admissions and in severe cases, admissions into ITUs or intensive care units. The others that we use is TPMT and NUD15. Again, this is used in cancer settings such as acute lymphoblastic leukemia for a drug called 6-mercaptopurine. And this drug with individuals who have variants have greater risk of neutropenia. The other variant that we test is a gene called NTRNR1 for a variant 1555, where adenine means substituted guanine. And this is for antibiotic class called aminoglycosides. And these individuals that have this 1555 variant are at greater risk of bilateral hearing loss after one dose at a normal therapeutic level of an aminoglycoside. And it's used predominantly in individuals where they're going to have a prolonged course of an aminoglycoside. And a good example of this may be individuals who have cystic fibrosis. So we can preemptively test them before they need the drug. So they're the main areas that we utilize pharmacogenetic testing for the commissioned genes that we have on the National Test Directory.
So at the moment, then, you're saying there's actually a really limited number of disease indications. We've got cystic fibrosis or a small number of cancers. Pharmacogenetics is currently being used in clinical management for. So it'd be good later in the conversation to understand how you think this might change in the future. But Dharmisha, say I've been a pharmacist for 10 years. How has my role evolved with the development in pharmacogenetics?
Yeah, so within my clinical practice, I've learned how to optimize medicine safely using blood results such as the liver and renal function tests and checking for drug-drug interactions and other clinical parameters such as blood pressure monitoring. So I still need to think about other factors such as patient age, their performance status, their compliance to medications. But now we have access to pharmacogenetic testing through the NHS National Test Directory. And within my toolbox, I now identify which patients are likely to develop side effects or require a different drug altogether. So we currently only have 4 NHS commissioned tests affecting drugs, which are used in very distinct specialist areas such as cancer and cystic fibrosis. But soon we will have access to testing for CYP2C19, which can be used for stroke patients, which will in turn affect more commonly prescribed drugs such as clopidogrel, proton pump inhibitors, and antidepressants. So within pharmacogenetic testing, I now have another tool to help optimize medicines. It should be noted that though I have pharmacogenetic testing, it does not replace my other safety measures, such as renal function, but it is an additional tool within my medicines optimization toolbox that I can pull out if I need it.
So, Dharmisha, you're a pharmacist. And could you tell me, is there anyone else that pharmacogenetics is actually relevant for? So any other healthcare professionals within the NHS?
Yeah, so pharmacogenetics is not only relevant for pharmacists, it's relevant to everyone that signs a prescription. So when it comes to medicines, any healthcare professional who prescribes, dispenses, or administers drug will need to know how to use pharmacogenetics as part of their daily safety drug checks. So this will include doctors, nurses, midwives, dentists, optician, paramedics, pharmacy technicians. So the list goes on pretty much.
It's quite a list, so thank you. So you've told us about those roles of prescribers and doctors, midwives, dentists have changed. At what point in these healthcare professionals' day-to-day jobs or the patient pathway should they be thinking pharmacogenetics?
Yeah, so within the patient pathway, we'll need to think about pharmacogenetics before we select a medication, and then when there are other drugs which are already prescribed to the patient, and if those doses need to be amended or adjusted, or if those drugs need to be changed in any way based on a pharmacogenetic report. We also need to know how to counsel patients when we think a patient needs a pharmacogenetic test, particularly if it's midway through their treatment, and how to explain that pharmacogenetic result back to the patient. And also, if other family members may need to be tested. So here I'm thinking more about the role of cascade testing, and this may be in distinct clinical areas, but it's the whole package of where we're thinking across the patient pathway spectrum.
Right. So as you say, Dharmisha, there's a real shift in how pharmacogenetics is now integrated in many different job roles from all the different prescribers in the NHS. There's applicability of pharmacogenetics in many of the steps along the whole entire patient pathway. So obviously NHS England is a critical player in determining to what extent pharmacogenetics is changing patient care. But how are they helping support the workforce, people like you, to use this genomic or genomic tools? I understand in January this year, NHS England released the Pharmacy Genomics Workforce Education and Training Strategic Framework, which is right up my street. Could you tell us a little bit about what that is, what it hopes to achieve, and your involvement in it?
Yeah. So the document sets out a 3-year approach on integrated genomic medicine into the pharmacy education training and including the workforce development. So within pharmacy, we want to empower the pharmacy workforce to use genomic tools to help support medicine's optimization to deliver benefits for patients. So to do this, there are 4 strategic aims within the document. So the first is integrating awareness of genomics as part of pharmacy practice. The second is building and joining networks. And then we have identifying pharmacy genomic workforce needs, followed by the last one, to educate and develop the pharmacy workforce. So this document is for specialist genomic pharmacists such as myself to think about how genomic medicine can be integrated into training programs and how we can upskill the pharmacy workforce over the next 3 years. The strategy is also important for pharmacy educators, so those that teach both undergraduates and postgraduates. because it sets out the value of case studies and clinical scenarios and other pharmacogenetic resources that can be used to help guide training within these scenarios. In terms of my involvement, I'm using this framework as a building block on the work I've already achieved. So, for example, we've developed a North Thames Genomic Pharmacy Champion Network, and we produce pharmacogenomic newsletters and webinars. But it is clear that there is much more to do. So, for example, to identify the workforce needs, I've been supervising an MSc student on a survey to find out how well pharmacists can navigate and interpret a CYP2C19 pharmacogenetic report. And this will help guide me on where we need to focus our training. However, the aim on educating and developing pharmacy workforce really requires a collaborative approach with educators. And there is an important element of educating the educator, as not all educators may feel comfortable in teaching genomics. I think this is really the next area of work.
So recapping that, so the new NHS England pharmacy genomic strategy aims to integrate genomic medicine into the pharmacy education and training to ultimately empower the pharmacy workforce to use this essential genomic tool. And I imagine then you'll be then cascading that out to other prescribers, for example, but starting with pharmacy first, so and building those networks too. So that's a fantastic ambition. So we touched on earlier the future and the possibilities. We always like to end on what's next in genomics in this space. So let's fast forward 2 years, 5 years. What changes might we see happen in pharmacogenomics or pharmacogenetics?
Yeah, so I think it's an exciting area, and I envision that we will have panel testing. For example, we will be testing for a larger set of genes linked to high levels of evidence, which we call tier 1 evidence, which will affect the prescribing of a number of different commonly prescribed drugs. So therefore, I really see testing move to primary care, such as GP services, over the more specialised hospital settings. So there will be, I also think, a widened use of point-of-care testing. For example, the mtRNR1 test I explained earlier for clinical scenarios where we really need to know the pharmacogenetic test results within an hour, for example, and that's a clear example of antibiotic prescribing that has to be given in an appropriate clinical time frame. And I think we'll also see pharmacists and pharmacy technicians being involved in pharmacogenetic pre- and post-test counselling, so really setting up the patient's awareness of the pharmacogenetic testing.
So really, it's that expansion. We've already got some pharmacogenetics in place right now, but then it's more genes, more variants, more associated drugs, and then actually what then involves in that patient pathway of counselling, etc., and then all the other workforces. So that's a big expansion. So great. Thank you, Dharmisha. I've really enjoyed this first episode of our pharmacogenetics series. And in the next episode, I understand we'll be delving into some of the fundamental genomic principles that you use and you had to learn. So I really look forward to that.
Yeah, I really look forward to that too. So thank you for having me on this podcast.
Absolute pleasure.
Thank you for listening to this episode of Genomics Now, a series of conversations hosted by healthcare professionals. The North Thames Genomic Medicine Service aims to complement other genomic-focused educational tools with these bite-sized podcasts. So do visit our website for more resources and updates on genomic-based clinical developments and research. If you've enjoyed this episode, don't forget to share your thoughts and spread the word by tagging the North Thames Genomic Medicine Service on social media.